Okay. So how many in the audience now have successfully logged on? Very good. So we'll start, and if anyone is having trouble, if I understood you correctly, raise your hand and someone will help you. So you will have successfully logged in if you have been randomly assigned to one of two teams. So let's see if that worked. So how many of you have been assigned to Team Toon? Very good. Okay, let's hear it for Team Toon. And how many of you have been assigned to Team Bird? Very good. All right. Now, don't worry for those of you who are still having trouble logging in, because the system is very adaptive. All you have to do is, as soon as you log in, you'll be brought into exactly where we are in the game. All right. So I first want to try to test like before. Hopefully you'll get it right this time, because we asked the same question this morning. There are two types of questions for Diagnosis Live. One question is, you'll see on your mobile device an image, and I'll ask you a question, a multiple choice question. I'll ask you to select a choice and submit it. So to test that out, let's ask this question that I hope everyone gets right, and we can see a lot of green there, so a lot of people remembered from this morning. When was the Royal College of Radiologists of Thailand first established? I will tell you, you people are so much smarter than the radiologists in the morning. Because of the radiologists in the morning, no one got it right, and now most of you have got it right. So you're learning. That's excellent. Okay. So as you can see, we have quite a few people who got this answer right, and very good. So we have the analytics that everyone does, and it's true. The Royal College of Radiologists in Thailand was established on June 14th of 1995. The second kind of question we're going to ask, on your mobile device, you'll see an image, and I want you to point to the abnormality, where the abnormality is. And then you point and you double-click, or depending on your mobile device, and then submit. So to test that, I'm going to ask this one. This one everyone got in the morning, so I assume everyone's going to get this right. Please select the chief of the first modern radiology department in Thailand. One of these three gentlemen is the first chief for the first modern radiology department in Thailand. Select who yes, and you all know who this person is. This person must be really famous, because everyone got this one right. Okay, well, a few people got it wrong. Must be the visiting professors. Excellent. All right, and so we can look and say, yep, a lot of people got this person correct. And yes, he is the chief of the first modern radiology department in Thailand. Excellent. So now we're ready to go. Again, I would like to give credit to the contributors of these cases, especially Dr. Katzman and Feinstein from my institution at the University of Chicago, as well as Dr. Panu, both of them, Panu, from Canada. They were contributors of many of the musculoskeletal cases. So the first case I'm going to show you, neuro case. MR study, what is your diagnosis? While you're doing this, as I explained in the morning, these cases we've had for many, many years, and we've given this diagnosis live all around the world. The goal of these cases is to hopefully have at least 60% of the audience get it correct. So right now you're perfect. You know, this is exactly, you're over 60% getting it right, so you should feel good about yourself. Your professors have done a very good job teaching you. So we're going to stop here. Very good. And as you can see, almost everyone got the answer correct. All right, this is an arachnoid cyst. I think the key point here is that, yes, the findings are iso-attend to CSF on all sequences. I think the key thing, and hopefully you will remember this because I might show you another case that is complementary, is that on diffusion weighting images, there's no restricted diffusion, as you can see here. And so the primary differential is that of an epidermoid cyst, which would show restricted diffusion, okay, because an epidermoid cyst might be in the same area. So excellent. Good warm-up question. Here's a nice warm-up musculoskeletal case. This is a 15-year-old with leg pain. What is your diagnosis? Getting close to our 60%. Good. Okay, so I think we're close to 60%. Oh, very good. Last few responses. Oh, well, the last few responses were wrong. Okay, so let's stop it there. Let me see what most people, everyone thought the most common incorrect answer was osteoblastic osteosarcoma. Okay, age group might be useful here. The most common, the most prevalent response was the correct one, which is good. This is a Ewing sarcoma. Again, age is useful. This is a very aggressive lesion, as you can see both on the radiograph on MR. You have a laminated sunburst periosteal reaction with bone destruction that's permeative. You have associated soft tissue mass. This is in the area of the metadiaphyseal location, and this is a classic location with the age. So as most of you got correct, very good, this is a Ewing sarcoma. All right, so much for the warm-up cases. So now let's go. Sagittal MR, patient with back pain. What is your diagnosis? Very good. Okay, you're doing very well. So, most people got this correct, that this actually represents infection rather than tumor. The findings here, we have abnormal marrow signal due to edema. The disc is also hyperintense on T2, and there's enhancement of both the bone, the adjacent end plates, as well as the disc space, which is pretty good for an aggressive process like osteomyelitis. Now, one possible distractor, one possible thing that you might consider in the proper clinical context is renal osteodystrophy, because that can resemble destruction of disc space, except for the fact that usually the distribution is a little different. It's in the cervical spine usually rather than the lumbar spine, and the disc is actually hypointense on T2. Very good. Here's our first touch question. I want you to double click, actually second touch question. I want you to click and submit where the abnormality is on this radiograph. Very good. Excellent. So everyone's got that one. That's pretty easy. Nice warm-up question. Everyone thought that, except for a few people, got the correct answer. And this is an enchondroma. Perfect. Okay. 6-year-old boy. 6-year-old boy. What is your diagnosis on this 6-year-old boy? You know, it's interesting. This morning there was a lot more collaboration, discussion amongst people. Everyone here is on their own, which is kind of interesting. I like collaboration. Collaboration is important. Just remember, you may be collaborating with someone on the other team. Okay. 6-year-old. 6-year-old. That's as much of a clue as I can give you. Okay. All right, so this one gave us a little trouble, which is good, because that's why it's great. Because if you get the answer, that's great. If you get it wrong, even better, because you're going to learn something. So most people, yeah, this is not a surprise, thought this was an ependymoma. Okay, the key point here is that you're right. From the imaging findings, this is a perfect complementary to the first talk. By the way, I love that first talk. That was, is the author still here around? Did he leave? That was a fantastic talk about being actionable and relevant. And one of the points he talked about is understanding clinical context. Clinical context is everything. You cannot just simply understand the findings in the images. You have to be a diagnostician. And when you look at this, one of the take-home messages here is you're right. There is nothing on these images that actually will distinguish this answer, astrocytoma, from ependymoma. You can't. All right? The findings are the same. You've got an expansile cord lesion that looks really scary. The key point is this is a young kid. All right? Young kid. The distribution of cord tumor in young adults and children is 60% astrocytoma. It is a more prevalent thing. But you're absolutely right. There is no way you can tell the difference on imaging, so you all kind of remember, all right, ependymoma, yeah, but that's for adults. So if I showed you this with an adult with a different history, okay, then you'd be right, because 60%, the majority, would be ependymoma. Okay, so again, clinical context, just like the previous speaker talked about, is very important. Okay, this is a 15-month-old toddler, young child, who doesn't want to walk anymore. And the patient came in, complaining of pain, came and looking, and this is a radiograph. And then 1 month later, this is what we found. What's your recommendation? Now, for those of you on mobile devices, you can actually zoom your image if you want. That might be more helpful. That's interesting. So I'm going to be very fascinated to see what people thought of this. Okay, so we didn't quite get the 60%. Let's see what people thought here. I'm interested. Okay, so the good news is the most common response was the correct response. But a very common answer is to do a skeletal survey, non-accidental trauma, which actually I like. Because when we show this case, I usually show it with... she applauds people who get number C. Even though it's wrong, she likes that answer because it means you're thinking about child abuse. You're thinking about that. And that's the role of radiologists, because frequently, at least in my country, the radiologist is frequently the first person to raise the possibility of non-accidental trauma. And it's our job to do that. But that's not what this is. And it's important to recognize that this is actually a healing toddler's fracture, which means nothing needs to be done on this. As you see, the initial radiograph at time of presentation is normal. But when you look, you have this really solid, but really kind of benign appearing periosteal reaction and this oblique sclerosis of the tibia. And these are pretty classic findings due to new stresses from increased ambulation. It's not non-accidental child abuse or some sort of metabolic or neoplastic process. This is a normal healing toddler's a fracture, and it's one that we can just follow and reassure the patient. Very good. Patient has a headache. What's your diagnosis? They don't need your help, by the way. Our famous neuroradiologist came, helping the team. They're doing well. They don't need your help. They're doing very well here, as you can see. Okay, people are doing well. So don't embarrass me. I just told our professor here that we don't need an expert neuroradiologist. You guys are doing very well, so don't prove me wrong. Very good. You guys are doing well on this one. Yeah, most of you got this one correct. This is an abscess. You have restricted diffusion within it due to all the proteinaceous and abscess material. T2, there's this nice hypointensive rim with capsule. Sometimes it can be hard. Diffusion weighting, restricted diffusion is helpful, but sometimes you still have a problem because maybe it might be necrotic tumor, and that's one of the cases where spectroscopy could help. Because in spectroscopy, MRS and spectroscopy, you would actually see compounds, amino acids, acinate and succinate concentrations in abscesses versus necrotic tumors. And it's one of the times when we have difficult cases where we might go to spectroscopy to see and to prove or confirm that what we have is an abscess rather than a neoplastic process. This is an axial and coronal projection, CT. With patient with neck pain, what is your diagnosis? I hate these kind of questions. Memorizing old people's names. But clearly you respect your elders and old people because you all doing very, very well here. So we'll stop here. Yes, this is a classic, a Jefferson fracture. We have offset of the left lateral mass. One of the pearls is when you're looking at this for trauma or something, make sure you pay special attention to the transverse foramen, making sure there may not be vascular trauma in that area. Sometimes you can be fooled. There can be congenital clefts or defects that can mimic this, but what you're looking for there is a well-corticated edge where there's still cortex there. So even though there may be a cortical disruption, as long as there's nice healed old cortex, you can usually distinguish this from an acute fracture versus a congenital defect. Excellent. Another touch question. Where's the abnormality? You might want to step back, do a selfie again, get that mobile device far away and take a look. That might be helpful. Might have helped. Yeah, this is a tough one. We'll see. Maybe a little unfair. I'm going to stop this here and show you. Let's see what people thought. Well, a lot of people got the right answer, okay, and then other people were all over the place. Yeah, this is avascular necrosis of the scaphoid. You can see the sclerosis and a little discontinuity of the contour. Excellent. Patient with back pain. Projectional radiography, CT, and MR. What is your diagnosis? Very good. Okay, people are doing very well on this case. Yes, this is everyone. Let's see, what did people see? Oh, okay. So yeah, aneurysmal bone cyst, very expansive, bubbly lesion. You know, narrow zone of transition. You see blood fluid levels in cysts. Many people tried to embolize this. It used to be that we would use radiation therapy to control this. We don't do that anymore because there is some evidence to suggest that radiation therapy may predispose to radiation-induced sarcoma. I purposely did not include another thing in the differential because when it gets this big, sometimes very atypical hemangiomas of the spine can mimic an aneurysmal bone cyst. It doesn't look quite as bubbly as this. The MR can be helpful, but when you see a big thing like that, an atypical hemangioma could also be something like that. We see that occasionally. Touch question again. Where is the abnormality? Okay. So remember this morning we talked about one of the most important roles we as radiologists have is we are the final safety net for patients in the hospital. That other physicians are going to commit what we talked about this morning, satisfaction of search errors. They're going to look, you know, there's a person with a headache or something. They're going to look at the brain. Only the radiologist will be disciplined or should be disciplined enough to have a comprehensive discipline survey so as to prevent missing things on the edges or things that people actually don't suspect. So let's see how you did. Well, a lot of people actually kind of got it right around the area here, but yeah, this is a choroid melanoma, and again, that's not that important to know. The key point is you want to avoid a satisfaction of search error. This is a trauma workup in a comatose patient. My question is the abnormality demonstrated? What is it? Very good. Excellent. You're doing very well here. You know, these are one of the cases where you either have to do your reading, you either know it, you don't know it, right? It's a good kind of case that we like to show to say, have the students been reading? Do they actually do their work? And you clearly have. This is clearly congenital. This is a Klippel-Feil syndrome, partially fused vertebral bodies with this tiny little rudimentary disc space. There's this wasp-like narrowing with fusion of the posterior elements. The classic triad of short neck, low posterior hairline, and limited cervical motion is actually a minority presentation. The phenotypic presentation that you read about is actually not as common as people think. All right, so we see this. The prevalence actually can be occult. Very good. Patient with ataxia. What is your diagnosis? Okay, it's going to be close. We'll see if we get to that 60%. It's a race. I think we made it. Very good. I think we made it. Okay, so interesting. Okay, so yeah, this is actually the most prevalent incorrect answer is not an unreasonable incorrect answer. So that's good. That's good. So we're talking about medulloblastoma. We have obviously expansile scary mass. The key point it's arising from the fourth ventricle. Okay, it's coming from the right. So that eliminates the glioma because that wouldn't arise from the ventricle. The key point where many of you, like I said, a not unreasonable wrong answer would be the ependymoma. The key, though, is these tend to be very plasticky, and they'll actually tend to, by the time that we see them, kind of creep up the foramen. All right, it's a very plastic kind of tumor. To have it kind of restricted there favors medulloblastoma, and astrocytoma would, again, be outside the ventricle, so that wouldn't do it. Very good. I'm curious to see what the score is. We're halfway through, so let's kind of check the teams. Again, Team Toon, just like the morning. So let's give a round of applause to Team Toon. They are winning again. And let's see what the top 10 players. Let's give the top. Oh wow, they're doing really well. Let's give a round of applause to the top 10 players here. They're doing really, really well as well. And just to remind you, at the end of the session, the winning team and the top 10 players come up and get your ribbon. A lot of you didn't get your ribbon. There's a little ribbon here, the little RSNA ribbon. Come get it and pick it up. And for those of you in the morning, if you've got to pick it up, come pick it up. You can brag or throw it away. I don't know. It doesn't matter. Okay, so let's keep going. This is another touch question. Where is the abnormality on this projectional radiograph? Okay. All right, we'll stop it there. All right, so this is a little unfair. Yeah, okay. So yeah, everyone kind of saw the edema. Okay, everyone saw the edema. That's normal, so that's not right. But a few got it right. Okay. Now the reason is you're spoiled. You want to see all the projections, right? But this is a little too far out. So yes, this is a secondary abnormality. The significant one is a medial epicondyle avulsion. All right. This is a patient with a headache. What is your diagnosis? Oh, very good. Chance for a few more points for your team. All right, excellent. Most people got this right. We got our 60%. Excellent. All right, I told you I would show you this. All right, if I'm going to show you arachnoid cyst, I'm going to show you this. All right, so the key point here is, just as we said in the first case, the warm-up case, the difference here is you have restricted diffusion. Okay, and that kind of helps it. This arises, the epidermoid cyst arises from the ectodermal inclusions during the neural tube closure, about the 3rd to 5th week of embryogenesis. It insinuates the cisterns, encases neurovascular structures, and it can be associated with neuropathy, specifically cranial nerves 5 through 8. Okay, key point, just before we showed you the cyst originally, that did not have restricted diffusion. This has restricted diffusion. And that's a useful differential feature. 50-year-old male, what is your diagnosis? Wow, near perfect response. Do you see a lot of this in Thailand? Is there a lot of it? Wow. I'm surprised. Oh, okay. Wow. That's so much better than other folks around the country. Is there a purine-rich diet in Thailand? Is it? Why do you know this? Are you all limping around? I mean, yeah. Oh wow. This is. I mean, like I said, we show this case. I show this case around the world, but I've never seen everyone. Oh yeah. Is the Thai diet purine-rich? I mean, is it? I mean, y'all. You're clearly not overweight. You're clearly not alcohol. I don't know. All right. So this is classic gout. Okay. You have these punched out erosions, thin sclerotic margins, paraarticular calcific deposits. You know, this is not that difficult for you. Obviously, it's not difficult. Generally speaking, when it is a differential challenge, for gout, there's still relatively late preservation of the joint space. You know, a lot of times the erosions will actually be more impressive than loss of joint space, which can be a helpful pearl when you're having trouble. But clearly in Thailand, since everybody has gout, it's not a problem. You all know it. That's fascinating. Okay, back to neuro. This is a slowly progressive painless proptosis in a patient. Slowly progressive painless proptosis. What is your diagnosis? All right. We're almost at to 60%. Very good. This is one of those kind of Ant Minis. You know it or you don't know it if you've seen it. Excellent. Most people got this correct, as you can see. This is an orbital cavernous hemangioma, you know, very ovoid, very well described, intraconal mass, isotense on T1, very homogeneously hyperintense. There's a little patchy enhancement that actually kind of fills in homogeneously. This is actually the most common adult orbital mass, at least stateside. I don't know, is it the same here? Is this the most common? Yeah, I guess people are nodding. Excellent. I'm not going to give you any history here. I want you to give me the diagnosis. Very good. Almost at the 60%. Okay. Very good. So most of you got the right answer here. This is an osteochondroma. You have exoptosis with continuity of the bone cortex and in the marrow space. The one pearl here is don't have osteochondromas lull you into a sense of security. If the clinical context has pain in the absence of a fracture, some acute trauma, nerve compression, some inflammatory process like bursitis, even though the radiograph may look indolent and benign, raise the possibility of malignant potential or malignant transformation. Pain in this context is not a reassuring sign. It is a worrisome sign. Very good. Another touch question. Where is the lesion? For those of us who are abdominal imagers, when I show this, at least you can flip a coin. Huh? That didn't help. Okay. I was trying to give you a clue. And we're almost 50-50, so it's just kind of flipping a coin. I find this case, I show this case every year, mostly because as a favor to a neuroradiologist, a friend of mine, because he loves showing this. It's because, you all do MR of the brain, but we tend not to concentrate on signals of normal structures. We just kind of ignore it. So now I give you this, and you go, okay, which side is the abnormal signal, right? Because I'm almost willing to guess you all, yes, okay, yeah. You're all, okay, it's one side or the other, I don't know, except for these guys. I don't know what these guys were thinking. I don't know, brain abnormal, I don't know. But yeah, but I find that fascinating, because we kind of don't have that in the abdomen. We kind of know what the abdomen looks like, but I find this interesting. Even when I show this in neuroradiology, you have to think a little bit like, oh, I can't remember which is the signal up or not. It's the right side. This is increased signal, right optic neuritis. So I find that fascinating. Anyway, 50-50. It was perfect. Okay, another touch question. Where's the abnormality? Remember I told you, I know you young people, oh, he's showing another radiograph. 70% of our work is still radiography. It's important. I know it's not sexy. You guys don't like it. But it's important. So, where's the abnormality on this? You're going to be so mad at yourself if you don't get this right. That's a clue. That didn't help. Okay, here's another clue. Remember we talked about what is the role of the radiologist? We're the only physicians in the hospital to do what? We're the safety net for what? That's not helping. It's making it worse. Okay. Well. Just be glad there are no older radiologists in the room, because they may be doing this right now. Young people. Okay. I can't give you any more clues. Other than, what section is this? Is this a chest section? No. It's either CNS or bone. All right, that didn't help. Okay, you're not going to be happy when you see this. All right.
Yeah, like the clavicle, lung, heart. Aortic ectasia. Yeah, okay, all right, yeah. No, look at that horrible. It is completely dislocated. I mean, it is nowhere near where it needs to be. Now, all right. Don't you feel bad? Okay. But it's not. Okay, so again, satisfaction of search error. The only way you're going to protect yourself, okay, is to have a disciplined survey. Look at the edges. Look for the free error. There's a very good line. A very famous radiologist, Ben Felsen. He's a very famous chest radiologist. When the giants roamed the earth. Okay, and he had a very good line teaching people their approach to the chest radiograph. And Ben Felsen said, if you're a young radiologist, save the lungs for dessert. And what he meant by that is, don't look at the lungs. Everyone looks at the lungs. Look at everything else. Eat your vegetables first. And what he meant by that is, look at the bones, look at the ribs, look underneath the diaphragms for organomegaly or free air. And only after you've exhausted your satisfaction of search survey, then you can have your dessert. Then you can look at the lungs, okay? Because that is embarrassing to miss, don't you think? All right. Now, obviously, this is artificial. Because the history you're going to get is not normal guy running in from... No, it's this guy's going to be uncomfortable, right? So he's going to give you some history. But again, this is an example where you really want to have a comprehensive survey to avoid satisfaction of search error. All right. 56-year-old female. What is the most likely condition? This is another case you want to do a selfie. Go way back. Take a look way back. Those of us who are old enough to remember film, we used to not only have magnifying lenses, we had minifying lenses. Remember that? And that can be very helpful. This is a case where looking back might help you. Okay. Almost got our 60%. We'll see. The Reds are winning. Oh, let's go. Come on, green. Oh, it's going to be close. Okay, that's enough. I think, yeah, we won. All right, so excellent. Okay, so very good. This is chronic regional pain syndrome. What you notice here, there's diffuse asymmetrical osteoporosis of the right hand, whole right hand, less signal. There are two types. Okay, they've kind of changed the name here. This is now called chronic regional pain syndrome. The first type, it's called type 1, where there's no associated nerve damage or nerve lesion that can be detected. It was previously known as, and how I learned it as, reflex sympathetic dystrophy, but that was kind of misleading because we're not quite sure what the etiology is. So now we just want to be descriptive, say this is type 1 where we do not see a discernible associated nerve lesion. Type 2 is where you have a detectable lesion with resultant pain along the distribution, so there's disuse and pain and people don't move, causalgia. So this is chronic regional pain syndrome. Excellent. Patient has rhinorrhea and nasal obstruction. What is your diagnosis? The most likely diagnosis?
This is interesting. Like I said, we show these cases all around the world. Everyone gets this wrong. It's kind of interesting. You're in good company. Don't feel bad. Everyone seems to miss this except the New Zealanders. It's interesting. I'm a body imager. This just looks terrifying to me, so I'm with you. I bet you I know what you all think this is. Let me see. Let's see if I'm right. Everyone thinks this is a mucocele? Oh, that's interesting. Okay, this is allergic fungal sinusitis. Okay, so you have this, expansile lesion, but when you look at it, especially the bony, it's expansile, but it's not super aggressive looking, right? I mean, it's been there for a while. You have a pacification, expansion of the multiple sinuses. It's in CT, it's centrally hyperdense and peripherally hypodense. In MR, you have T2 hypointensity, believed to be because it has a lot of fungal concretions and heavy metals. It can actually mimic air. It can have a very low signal. That can be helpful. It tends to be in the ethmoid, then maxillary, frontal, and then sphenoid sinuses, and it's probably a type 1 IgE-mediated immune response to fungus. So that's sinusitis. All right, so we have a few more minutes, a few seconds, so let's go really quickly here. 43-year-old male, what is your diagnosis? I'm going to give you 45 seconds for this one. Last chance to get a few points for your team. Excellent. Beautiful. Okay, so everyone said this is good. Everyone correctly identified this is infection, this is septic arthritis, it's monoarticular, there's destruction, swelling. This is a clinical emergency. This is one like our previous speaker. You want to have an actionable report, you want to be timely, and you want to communicate immediately to the ordering physician. Typically, aspiration to isolate the organism and aggressive therapy is indicated. All right, another touch question. Where is the abnormality? I just realized you may never see this here. I'll explain in a bit what the you may not. Oh no, you're getting it. Because the most common etiology, the mechanism for this doesn't exist here, but we'll talk about it in a bit. Okay, we'll get there. So, excellent. You all kind of, all over the place again. But most people, a lot of people got the, why do you get this here? What is the mechanism for a triquetral fracture in Thailand? How do you get this? I don't, Muay Thai? I mean, how do you break it? Because in the States, the most common thing is falling in ice. And you break so how do you, we'll talk about that. Someone teach me how Thailand people get this fracture here, okay? It's kind of interesting. All right, what's your diagnosis? No history. 45 seconds, we're getting near the end here. Very good. You don't need 45 seconds. You all know this. You're well trained. You study very well. Dandy Walker malformation, large posterior fossa cyst, hyperplastic vermis. This is part of a continuum, and that's the one
point. It's actually, the classic malformation that you see here. Actually, there's a spectrum. You could just have just a big cisterna magna. So there is a spectrum. Excellent. No history. What's your diagnosis? Very good. Yep. I'm going to stop it there. You all got that. No problem there. Yeah, this is a carotid classic location, very vascular lesion. I think the pearl here is when you find one, look for others, because it's common to have multi. Okay, let's do one last one. Touch question. Where is the significant lesion? Okay, a few more seconds. It's a race between the... wrong answers are winning. Okay. All right, we're going to stop it there because we're out of time. All over the place again. But there were quite a few who got this. That's a little low, guys. It's a little too inferior, as you know. You guys did great. Let's see who won here. Okay. So look at this. We'll look at the scoreboard here and the teams. And once again, Team Toon. Let's hear it for Team Toon. They won both the morning session and the afternoon session. Your professors will be very proud. Please, especially many of you forgot to get your little ribbons. I tell you, at the RSNA, people love these ribbons. I don't know why. But please pick up if you're on Team Toon, please pick up your ribbon and you can show off. You can put it on your badge for one extra day. Also, let's get a round of applause for these 10 radiologists. These are outstanding scores for this session. They should be very proud. Their professors are very proud. Also, these 10, please come up and get your little ribbon. You can brag for a couple days on that. I hope you enjoyed these sessions. This is my last talk to you guys. I just want to thank you for your wonderful hospitality. This was a wonderful meeting. I enjoyed being here, and thank you so much. Take care.